Thank you for the introduction, and thank you all the organizer for the invitation here to give this speech. So first of all, I would like to say I have no financial interest to or relationship to disclosure with regard to subject matter of this presentation. So today my topic is clinical fMRI psychiatric applications, and I have to say this is a quite big topic, and I'll try to convey the main ideas based on two aspects. First, some general information on psychiatric disorders, which I think is needed because that will give the basis why we need both fMRI and what we can do using both fMRI. So to start with, some burden of the psychiatric disorders. We use a word DALY, daily, which is disability adjusted life year, to measure the burden of certain diseases. And we find that, you can see that, because daily is composed of YLL and YLD. And for YLD, which means the year lost due to disability component, we can see it's mainly the mental and substance use disorders. So they were the leading global cause of all non-fatal burden of diseases. So on the right of the figure, we can see that the most common psychiatric disorders in the lifespan, what the cause of the burden. And one of the things I think need special notice that we can see for most disorders, the most severe burden was caused from the early adolescent to the young, early adolescent to the like about 30 or 40 years. So that's the main time when people were most productive. So with this, you may think that it's not a death disorder because it's not the YLL. We can see it's very, very short, the red one on here, this one. So it's not like the cancer or other disorders we think so, but we see about the death. But in fact, we know that there's a serious problem like suicide, which is caused by psychiatric disorders. Just like about 1 week ago, we know there are some famous people who died from suicide. And also there is some epidemiology data showing that just for MDD, the major depressive disorder, we see that the suicide rate is much higher in this population. So now we came to the question, because there are so severe diseases burden with psychiatric disorders. So the question is, why we have mental disorders? And I think this is the first question human beings facing any diseases. But the difference is that for any other physical disorders, for the past 100 of years, we use biopsy and we get the pathology of it. So we have the golden standards for almost every diseases physical disorders we have now. And after the biopsy, we can see, okay, these people, what kind of is like, just like the first speaker in the pre-surgery mapping, you need a biopsy to know which kind of cancer it is in the brain. But for the brain of mental disorders, when there's no obvious lesion, how can you get a biopsy? You don't know which part of the brain is being affected. That's one thing. The other thing is that think about get a biopsy for a living human being. I don't think that's a feasible thing. And several years ago, there's a lot of post-mortem studies to see the people after death. But just now we mentioned that for psychiatric disorders, they will not die when they will just have this disorder. So there may be several years, like decades, when they died. So at that time, if you do pathology, what you find in the pathology, it may not directly correlate for the symptom when the people is alive. So luckily now we have the image, and we hope image can be a biopsy for the brain to understand the pathology. So then the second question is, can we find a biomarker to evaluate this disorder? So that is, even sometimes for some situation, we do not currently know exactly what is a pathology, but we need a marker to tell us what we should do in clinic, like what kind of diseases what kind of medication we should, or treatment we should choose for this particular patient. And we would like to know if there's a marker to let us know the severity, the prognosis of the patient. So that means if they will be going to be worse, they were going to be just an episode and then come back totally in a good mood again, or something like that. So for this matter here, I would like to see what the image can do is something here. This figure is from one of the articles published in Nature Medicine, so it's a review. We can see that for fMRI, it's mainly on the systematic review. So what I want to point is, the previous slides we show that we want to use image as a biopsy for the brain, but we need to know to what standard or what scale it can tell us about brain abnormality. So also there's another one, the Time issue raised in the Science article in 2015, and which he thinks that the symptom-based category of the mental disorder need to go to the data-driven category. And in the integrated data, we can also say that the brain activity is also just a part of the data we needed. There's another from genetic to the life experience one. So, oh, that's wrong. Okay. So then the third question is, what is the diagnosis based on? As I just said, we still do not have the basis of the pathology for the neural basis for the pathology. So then how can we make diagnosis? So I have to say kind of like, unfortunately, after several years, decades from the DSM, which is the diagnosis system in the US for the mental disorders, from the very first version to the now, the popular DSM-5, still is symptom-based, though we see that there's a lot of new diagnosis categories because even the mental disorder itself is changing with the change of the society. So just like what I talk, I think the three questions with these three things which is not known in the psychiatric disorders. First, the etiology is unknown, the biomarkers are undetected, and the diagnosis is unsettled. So with these three questions, the later part of my lecture here will be given according to how can we use both fMRI to understand the mechanism, to doing some kind of prediction, and also to do the classification and the subtyping. So start with the mechanism. First, we know that fMRI of the brain at rest gives us a very good tool nowadays because when you think of a subject in the mental state, and it's very hard for them to finish some kind of like cognitive task or something, even outside of a scanner. So I think the scanned brain at rest is a very operable process in the clinical setting, and it may be has more potential to be useful in the clinical than task in the real time. And mainly there are two kind of, I think, measurements for the resting state. One is we use it to measure the local spontaneous neural activity, which we think represent the local neural activity. And another way is we using like the functional connectivity analysis or the now more popular graph theory analysis to describe the whole brain from a network point of view and to discover which part of this network has been destroyed or something. Okay, so I would like to introduce one of the large cohort study our center has been doing about 10 years ago. And at that time, we were trying to recruit the first episode, schizophrenia. Here we use the first episode because when you want to explore the pathology of a disorder, you don't want this pathology has been blurred by other confounding factors, like for mental disorders, if they were in a chronic state, they have a long illness course, they may be comorbid with other symptoms, and also they use the antipsychotic drugs, which surely have the kind of effect on brain structure and function. And also some people, they were trying to study if there's a pre-dream period when the first after the pre-drama period, when they first have the episode of representation. So we think for this kind of mechanism study, it's very important you have a relatively homogeneous subject, so it will not in fact have an effect on the final result, how you explain the neural image findings. So one of the first paper we were published at that time was we just studied 66 first episode of schizophrenia with the 66 healthy controls. And the image data analysis is very easy, I think, from the current point of view. We just use ALFF as the parameter to measure the localized regional brain activity and then do the simple whole brain, the two-sample t-test and Paris correlation to see if the change was correlated with some clinical symptoms. What we find mainly is that the decrease of the ALF in the MPFC region and the increase of the ALF in the in the subcortical regions. And then, with this, bear this in mind, later we will talk that later. And in another study we were trying to see is the functional connectivity study, because we know that when there is a regional change of the brain, we want to see if there's a network, there's kind of abnormality from a network point of view. So for doing this functional connectivity study, I think we first did a VBM analysis to locate 3 regions which has decreased volume, which is in the right STG, right mid-temporal gyrus, and right ACC. And then using these 3 regions as seed, we did a functional connectivity analysis, and to find that the functional network involving the right STG and the middle temporal gyrus were associated with the clinical symptom severity. So that paper was published almost 10 years ago, and that when it was published, the editor of the AJP of that said it was the first study to try to combine associate the structural abnormality with the functional change in this particular patient group, and also to find some of the association between them. So then, after that, we were trying to see what the drug effect would have on the functional connectivity study. As we mentioned before, everyone knows the drug would change the function of the brain. So we will see that there are 34 FES patients we were able to scan twice. That's after 6 weeks of antipsychotic treatment. And then what we find is that here you see this is at the baseline. For this small group, we get the similar result as just now we see in the big group study. That's a decrease of the ALF in the prefrontal area. And then after just 6 weeks of antipsychotic treatment, we can find that there's obvious increase of the ALF in multiple brain regions, including prefrontal, parietal cortex, and some other regions. And also, they were correlated with the symptom reduction. And also in that study, we tried to see the functional connectivity changing in this short 6 weeks antipsychotic treatment. And what we found is that we see here the black line is which the functional connectivity do not change. And the red line means that when they have abnormal functional connectivity at the very start, and then they were kind of like changed to normal after 6 weeks. For the green line, we were showing the brain region which is normal, but then they were changed due to the antipsychotic treatment. So then this is about schizophrenia. Another study we were doing about MDD, the major depressive disorder. We use the graph theory. And for graph theory, it's mainly interested in see the small world parameters or something to define how is that a network. We can say it's kind of like shape the network is changing, because that's the way of how brain functioning properly with integration and segregation. So in that paper, we mainly find that compared with control subjects, the MDD patients saw the shift toward randomizing the brain network. And so then we were still talking a little bit about fMRI. I think one of the challenges when doing the functional measurement of the brain is that sometimes the brain function in a particular mental disorder may be not that obvious. It's very subtle. So that means they may not exert some kind of abnormality when they were at rest. But then if they give you a task, you give them a task, they would have some abnormality when they were at work. So that's why still functional MRI has a lot of way, especially in exploring a particular neural circuit activation in the brain. So for this, in this respect, I will just introduce 2 recent meta-analyses. And for those of you who are really interested in this area of research, I think you can go further and have a look. Because this first meta-analysis of the German Psychiatry published, I think, 2015, they find that the brain regions with significant differences in activation between youth and major depressive disorder. And they even find the neural basis of major depressive disorder in youth based on what they find in that meta-analysis. Especially they find it in different tasks like here. And another one published on the same year of the molecular psychiatry, they were trying to combine all the fMRI study which referring to the antidepressant effect. And as I said, this is very important because the final goal of all the findings, what we are doing now is we hope there will day we will know how the drug is doing exactly on this particular person. So doing the drug effect is very, I think, important region of the research. And what they have combined is from 60 fMRI studies, which had been compared the antidepressant effect on both MDD and volunteers. I think the main thing they found of interest is that they found antidepressant can increase the brain activation on positive emotions, but decrease the effect on negative emotions. So that is what we see why in some people they will have more easily get happy, and when depressed, you just cannot get happy. So then another thing about prediction. For the prediction, we just, in our center, we did a very large study, which was also because of the tragedy story 10 years ago. Exactly 10 years ago, there was a terrible earthquake just near Chengdu. So our center, the biggest hospital at that time in China, so we have a lot of also the survivors from the earthquake. And we were trying to see what the brain function would be changes after that terrible earthquake. So, and then after 2 years, we did a follow-up study for just 24 and to see what would changes. What I would like to mention is all the people we followed in this study do not have PTSD. So that means in this study, we were trying to see the brain functional changes in people who after a stress, a trauma, but they do not get PTSD, what would the brain functional changes? The first article published on PNAS is on a very short time, and we see the obviously change of the regional functional changes from ALF and from the FC. And also this is like the ALF is correlated with the self-evaluated symptom of anxiety and depression, which is just we use the simple scale of SAS and SDS. So with this first study, we were thinking, okay, because they were highly correlated, is that possible we can use this parameter to predict the symptom of those subject after maybe like for the second time when they were scanning after 2 years. So what we get is that we did find that we can use the ALF to predict the symptom, and they have a very high correlation for the actual measurement and the predicted measurement here on this figure. And also the places which we can show with the distributed some of the regions which is most informative for the SDS prediction, and some of for the functional connectivity FC, which is we can use it for the SDS prediction. So then there's another study we did during the course that is about 1 year around after the earthquake. And another collaborator is doing a large screening for the population at that time to see if how many people would get PTSD. So we will recruit another over 100 population, and we using in this study we used the RVR method to evaluate the potential of resting state function MRI to still accurate predict the psychopathology at the high risk of developing PTSD. So there's another one article on the previous schizophrenia data we've collected, because after several years we have more than 100 schizophrenia. And in this one we doing with a collaborator from Yale who find using a way called RGBC is also a way to measure the connectivity between the voxels. And what identify is hyper as well as hyper connectivity of different frontal cortical regions like here. And the most interesting part is that what she also found in this article is the way to use image marker to correlate with the symptom severity. PANSS is a special scale for the schizophrenia evaluation. And then we find that they can also show a promise for the diagnostic classification here. So from here, I'm going to talk a little bit about classification. Because for classification, it's very popular, like many people using machine learning or even now try to use deep learning. So I will introduce one study just published last year on Nature Medicine. And in this study, I think the most interesting thing is that that's a very large sample size study for over 1,000. And the first society, they're doing some mathematic things with some algorithms, so they find for connectivity-based biotypes of depression. So this is more likely to be algorithm. But then with these biotypes of depression, they find that this kind of biotype depression is distinct from clinical profiles. So that means it's not totally the clinical classification we used to do. And then they use this biotype to see if it can be used to classify the patient and give a good sensitivity and specificity, and it works well. And finally, the most important two things is that first, they find that the connectivity biomarkers can predict differential antidepressant response to TMS, transcranial magnetic stimulation, which is a very popular treatment for depression now. And then they find that this is also can transcend the diagnosis boundaries. That means between the diagnosis of different mental disorders. So there's another one using the functional connectivity to doing something about the classification of ASD, and I'm not going to talk more about here. So for our group, we were doing some subgrouping things based on gray matter and white matter. So because this session is about fMRI, so I'm not going to talk too much, but I would like to remind that in fact the exploration of the mental disorders and also all these kind of things is not confined to functional MRI. And finally, we need to combine the different modality for the different purpose we want. So for people who is more interested in knowing more detail about these studies, there is a session this afternoon for the neuropsychiatric disorders. Yeah. So finally, take-home message, there are three. I think the first thing about mechanism. The full understanding of the mechanism will still be on the exploration road, as the normal brain function is not yet understood. I think everyone understands how. But just to remind, if you are trying to explore the mechanism, you need to be careful about the subject selection. The second point is that the prediction for prognosis relevant to symptom relapse or treatment relapse are most likely to be used for biomarkers in clinical application. So here, different with the first thing is that when you're doing this, you are not care about what kind of the patient. You don't want a too homogeneous patient. In fact, because when you make the decisions in clinic, you will not say, okay, I only have FES, the first episode patient. You will have patient of various kind. So if you want a marker for the clinic usage, maybe you need to consider what you, just a general thing. It can give you a hint if there will be good response to a drug or not. And the third thing, classification and subtyping should be aim-specific instead of just a new set of taxonomy. So we just don't want to be, we have a symptom-based classification, and then we change it totally to some AI-born machine learning how can I say? New taxonomy, so still we don't know what to do with it. So I think the advancement of all this tech knowledge is to making, the final goal is to improve the human mental state, yeah, which has been for hundreds of years. So just like Van Gogh, we know that he's had a serious mental problem. So finally, most work has been done with many collaborators worldwide. But today here, I would like to thank the people from my group who helped me a lot in prepare these slides. And thank you.